on discuss, like if it means we do not have the rightful resources, what can we get to use so that we maintain a standard? Next slide, please. Right, for the IPC strategies, these will be emphasized on a weekly basis. Basically, what we are looking at today is to ensure that there is triage, there is early recognition and source control, which is isolating the patients with a suspected COVID-19 infection. And as we all know, triage is the first step of identifying suspects. And what is important is we always have to use the updated case definitions when screening. And for triage to be successful, we also have to ensure that we still maintain standard precautions and we implement the empiric additional precautions, implement the administrative and the environmental controls. Next slide. So when we are looking at the hierarchy of controls, we are trying to look at now the PPE being the list, the administrative, the engineering, and also getting to identify the hazards and removing that hazard from everyone else. Next slide, please. And just in a nutshell, I will talk of the administrative controls in passing. This is where we get to be trained as healthcare workers. And what is also important during an outbreak season is to establish a surveillance process for the acute respiratory infections potentially caused by COVID-19 amongst healthcare workers. So in addition to triaging, screening and triaging our clients as they come in, we also have to be screened on a daily basis as healthcare workers when we report on duty. Next slide, please. And then for the engineering and environmental controls, we are going to be addressing the basic infrastructure of the healthcare facility. We're going to also look at ventilation as it plays a very important part in the looking after the COVID-19 patients. And we're also going to emphasize on the special separation of at least 1 meter or 3 feet, which should be maintained between all patients. And in addition, we need to have adequate wash infrastructure and environmental cleaning, and also look at waste management issues. Under PPE, we have to perform a risk assessment based on the potential exposure and the risk. And what is important there is we have to wear the personal protective equipment properly, and also remove it safely and dispose it safely, and above all, perform hand hygiene the proper way. Next slide, please. So to facilitate the early identification of cases, we need to establish a well-equipped triage station at the entrance or entry point, which is supported by trained staff. So we are going to look at this in detail on who is supposed, which is the rightful cadre to be doing this, the screening. And we should also look at how we encourage healthcare workers to have a high level of clinical suspicion. For example, this is where we are looking at our patients who do not meet the case definition, but somehow you feel that the symptoms that they are presenting with are likely to be COVID. And then we institute the use of screening questionnaires according to the updated case definition, and also look at the IEC material that we use to sensitize our communities or our patients as they come in to seek health services. Next slide, please. So basically, what is this triage that we're talking about? Triage is actually a process which rapidly examines sick individuals when they first arrive at the healthcare facility in order to place them in defined categories. And you separate those with priority signs and those with emergency signs. So this with priority signs, they should be given priority in the queue so that they can be rapidly assessed and treated, either moved or isolated without delay, so as to minimize transmission. And those with the emergency, they require immediate urgent treatment or attention, so hence they have to be attended to as an emergency. Then those who have no emergency or priority size, then they can wait for their turn in the queue, provided we have gotten to screen them. Next slide, please. And then for us to start the triage process, we have to look at the signs and symptoms. And most commonly with COVID, our patients will be presenting with a fever or a cough. At times they can come in with a sore throat, shortness of breath, and a headache. And rarely do they come in with a runny or stuffy nose. But this you are mostly guided by the case definitions. And then next slide. So this is an example of the screening or triage thing that is used in South Africa. This is what they get to ask the patients. They are priority patients. They'll be looking at those presenting with acute respiratory illness with a sudden onset, and at least one of the following, which is either a cough, sore throat, shortness of breath, and a fever. So if such a patient presents at the triage, then they can be put as a priority. Next slide, please. So who needs to be tested? So this can only be done at the triage area, because you have to prioritize those that are at high risk and then those that have to undergo investigations. Next slide, please. And then you have to use a screening tool. So that is one example of a screening tool. This one is used in South Africa, and you have to ask the clients or the patients as they come in, and if they answer yes to any of those, then you can institute further investigations. Next slide, please. And then this one just graphically shows the routes of transmission. Hence, that's why we need to keep our patients within a meter, 2 meters apart, so that we minimize the risk of transmission of the droplets. The next slide. And then what you get to do to effectively manage the patients, you have to develop an algorithm. This is facility-based specific, because it's not a one-size-fits-all. This addresses how the flow of the patients as they arrive in your health facility. They may be coming from, they can be brought in by an ambulance, they can be a walk-in patient, or they can be brought in by the relatives. And then from there, you have to triage them. And if it means they meet the case definition, then you have to remove them from the rest of the patients and put them in a holding facility, and you continue with the care. For those that do not meet the case definitions, then they can proceed through the other routes so that they can get their treatment. Next slide, please. So a suspected COVID patient must be first screened for the disease, then isolated from other patients, and then the right authorities notified. So this is where we get to follow the screening, isolation, and notification protocols. And these are also country-specific. Next slide, please. So who should be a screener? Because that is where we are starting. So ideally, a nurse would be the primary screener, because they will be taught on how to recognize these signs and symptoms, and also take the essential vitals, which in most of the cases, it's the temperature check. And then if it means that we are human resource constrained, if there is a nurse aide that is available, they can be taught on how to screen the patients as they come in. However, what we should note is the security guards should not be given the job of screening patients. They can direct the patients on where they are supposed to go, but it is not their mandate to be screening the patient. And then a clinician should always be available also to provide support to the screener when complicated cases arrive. And this is a time whereby maybe the patient does not meet the case definitions, but with the signs and symptoms, or you strongly feel that the patient is likely to be a COVID-19 suspect, you can then ask the other clinicians in the area or in your facility to assist you. So next slide, screening should take place at the entrance of each health facility, and it should be done at all times during all shifts and for all persons entering the facility. This is also inclusive of the healthcare workers. And then the area should be well stocked. They should be a working thermometer, the adequate or appropriate PPE, and hand hygiene facilities. And then for using the judgment, this is what I was earlier on alluding to, that if you feel that the patient presents with suspicious symptoms but does not meet the criteria for isolation, you can then engage other healthcare professionals in your facility. And if it's a visitor or it's a caretaker or it's a staff members who appears ill, they should also be screened before entering the facility. Next slide. So for the triaging process, you have to ask the patients, what is important is for you to ask if they have any symptoms, and at the same time, you should pay particular attention to hand hygiene and teach our clients how to perform proper cough etiquette, that is covering their cough with tissue, throw it away and disinfect their hands, and also to maintain at least 1 meter apart from each other. Next slide. The screening process, the process of screening is effectively is more important than the place of where the screening occurs. And next slide. So we need to address a number of IPC issues when setting up a triage area. And these are outlined in the next slide. So the screening, the triage area should be placed in a well-defined area with proper ventilation. And then there should be appropriate distance between the healthcare worker and the patient, and also between other patients. And then it has to be well stocked with PPE. It should have hand hygiene facilities, should have an infrared thermometer, and an algorithm for triaging, because it's important for us to know that if the patient has symptoms, which route are they supposed to take, so that they do not mix and mingle with other care activities happening. We should have a screening questionnaire, and this questionnaire should be very simple, and the person asking the screener should understand the questions in that questionnaire. There should also be provision of waste management, clear signage, so that everyone gets to know where they should report to as they enter into the facility. And then they should also make use of posters which teach our clients information about the transmission mechanisms and how to prevent further spread between each other or in the community. Then there is also supposed to be documentation. These are in the forms of registers, whereby you have to enter the patient's name and other demographics like the age, where they are coming from, their telephone number for purposes of contacting, and the important contacts like the next of kin who we should reach for in case you need any further information. Then for the PPE, there are questions that you need to ask yourself. Is it designed for the task at hand? Is it disposable or reusable? How often should it be changed, cleaned or disinfected? And is it available in the several sizes? And if yes, you should know what size is best for you. And then if there are any other problems that you should be aware of, that is the supply, the storage, and the availability. For the PPE, it will be further discussed on the next webinar next week. But for the triage, next slide. For the triage, if you are educating and screening the patients, you should only stand 1 to 2 meters between you and the patient, and you need only a medical mask. Next slide, please. And then if you are assessing the patient, you are then allowed to put on goggles or a face shield, a surgical or medical mask, gown, plastic or a plastic apron, and some gloves. Next slide, please. And then if you are now testing, that is collecting the sample, because that is now an aerosol generating procedure, you then substitute the mask with a respirator in the form of an N95 or an FFP2, and you also put on your goggles, your gown, and gloves. So this will be discussed in detail in the next lecture, that is next week. Next slide. And then this just shows how you can get to use the infrared thermometer. You should hold it at 3 to 5 centimeters from the person's temporal area. And if it means you have a recording of less than 35 degrees Celsius, you have to retake the temperature. And if it's more than 38 degrees Celsius, it's indicating a fever. Next slide, please. And so that's just a graphical presentation of where you should position the thermometer and how you should take the temperature. Next slide. Additionally, the triage area should be as close as possible to the healthcare facility main entrance in order to centralize all entrances. This is very important. If your healthcare facility has so many entrances and exits, you then have to do a risk assessment and try and find out which is the best area or areas where you can set up your triage stations, so that we try and minimize, or we try and not get to miss patients that will find their way into the healthcare facility without being screened. And then there should be unidirectional flow of the patients. That is, we are moving from the clean to the dirty areas and not vice versa. And the staffing should be the right cadre, and they should cover all the shifts. And then if there is no existing building, we can make use of a tent. We've got some pictures in the course of the presentation in which you can use depending on the setting that you are coming from. Next slide, please. And then you ensure the following infection control measures. That is the cough etiquette. You can offer a medical mask to those who have suspected COVID-19 infection. You perform hand hygiene, and you routinely clean and disinfect surfaces where the patient has been in contact with, and you can have a checklist to verify that. You apply your standard precautions at all times, and additional precautions if need be. You don the right PPE for the right procedure, and then you refrain from touching the face with potentially contaminated gloves or bare hands. Next slide, please. So moving from the screening to the isolation, if the patient has symptoms and signs, then the next thing is they have to be isolated from the rest of the patients. So how do we get to do that? Next slide, please. So depending on the facility that you are coming from, you have to move this patient from the triage to a holding area or to an isolation area or a room. So they can be a temporary holding area if it means your facility does not have the capacity to nurse, to admit patients with suspected COVID-19. So if the transport is required, you use the predetermined transport routes so that you minimize the exposure to other staff, patients, and visitors. And then you also ensure that the healthcare workers who are transporting the patients are donning the proper PPE and they perform hand hygiene at the right times. You also notify the area receiving the patient of any necessary precautions as early as possible so that they start preparing for the patient before their arrival. And then you also limit the number of healthcare workers and others who have contact with the case. And then you maintain the accurate records for all the persons entering the patient's room, including the staff and visitors if there is need be. Next slide, please. Then for the isolation area, it has to have a clear signage so that everyone gets to know that that is not an area where people can be freely moving. So there, if you can point the pointer on the pictures, these are some of the examples whereby you can put the precautions in place, and these should be showing once you see them, then it means you stop and you have to talk to the person in charge of the area on whether you should proceed or not. Next slide. Ideally, you should place the individual in a single room with an adjoining dedicated toilet. If a single room is not available, you can place or cohort the patients in specific confined areas, and then you place at least 1 meter distance between the patient beds. You rope off, or you can put a border around the area to prevent entry by non-essential personnel, and you assure that there is good ventilation, and you do not use fans or air cons in that clinical area. So I would suggest that you try and open the windows so that you they can aid in ventilation. Next slide, please. You assign a personnel who is exclusively working in that particular area, and the staff should not be moving freely between the isolation area and other clinical area. And then next slide. So if you have no isolation room, what can we do? How can we separate the patients from others? What space which exists can we adapt? And we also, does it have good ventilation? Can it be reached without going through crowds? And if not, how can we move the patient? So in the next slides, we're going to discuss in detail how we can put triage or holding areas if it means we do not have dedicated space. Next slide, please. So how do you set up this holding room? Next slide. If you do not have a room, you can demarcate the area with a chair. You can even use a tent. And then if you have demarcated the area with a rope or a chair, you then restrict the access. You avail basic PPE, and then you still maintain the distance of 3 feet or 1 meter. The hand hygiene stations should be outside the area. You should have a dedicated staff, and you keep a register of who goes in and out. The next slide, please. This is basically showing you how you can improvise in setting up a triage area right up to isolation process. The first picture there is a tent, and then in the second one, it just shows the classification of how your patients can get to move. The third picture is a temporary holding area, and then the fourth one is a tent that has been designated now to isolate the patients. Alternatively, you can use the chairs, like we said, but you have to improve ventilation by opening the windows. Next slide. And then you can create a register. It doesn't need to have a book, but you can use your bond paper and ensure that you put the adequate headings for you to get all the necessary information. For hand hygiene, in low to middle income, in low income settings, you can see the non-touch techniques that are being used in Africa is to improve hand hygiene practices. Next slide. And then you have to perform the hand hygiene. You have to put your posters reminding the staff and even visitors, patients, on how to hand wash or how to hand rub. And as we all know, this has been revised, the how to hand rub, starting with the fingertips first. Next slide. Then moving from the isolation to notification. If the patient, you now know that the patient has symptoms and exposure and is now in the holding area, you then have to notify the relevant authorities. So this differs from facility and country by country. In other facilities, you start by informing the rapid response team, which is mostly made up of the infection control personnel, the clinicians, and part of the hospital management, and then the system feeds right through up to national level. Next slide. So in summary, on triage and isolation, we have to implement screening for cough, respiratory symptoms, travel history at the entrance of each facility, clinic, casualty, or hospital. And you put a sign up which is asking for persons with a travel history or contact history to identify themselves to staff, and then you provide surgical masks to people who are sneezing or coughing, and you attend to the people who have the signs and symptoms first, and you encourage hand hygiene amongst patients and healthcare workers. Next slide. So the key messages, the take-home messages, we shouldn't be turning patients away. When a patient presents, let's try and triage them and follow the necessary steps. We look at the symptoms and the exposure to determine whether the patient is a suspect. And if we now know that the patient is a suspect, we keep them, we separate them, and we send them into the holding room and then get to notify once we have done all the necessary procedures according to the facility protocol. And then most importantly, you should protect yourself. That is through the use of standard precautions in combination with the cough etiquette, the distance, and the use of appropriate PPE. Thank you so much.
Thank you very much, Lizzie. I'll open up so Edouard can ask questions if there's anything.
Thank you very much, our presenters for today. So as many questions that you have, kindly put it in Q&A. Then if you have any burning questions that you want to ask, you can raise your hand. I'll recognize you and give you mic to ask your question. So I can see that 3 people have raised their hand. So I will start with Maxwell. Maxwell Johanel. Oh, it seems Maxwell is no longer raising his hand. Maybe Mola Godif can go ahead. You already have your mic. Just unmute yourself and ask your question. Hello, can you hear me?
Yeah, hello.
Yes, please go ahead.
Okay, thank you all guys for providing and facilitating this very important IPC training for member stating. My question is that how much disinfection using chlorine 0.5% is effective? Did you hear me?
Yes, we did. Shadai, do you want to answer?
It's about disinfection. Disinfection. You know, mostly we are requested just to conduct disinfection in patients, confirmed patients or suspected case of COVID-19 were staying. So which type of disinfectant chemical are we going to use, or is chlorine 0.5% is effective?
Today?
Sorry, you can use chlorine, the 0.5% for if there's environmental contamination. Yes, you can.
Thank you.
You can wash
And
as
then
well.
you can use 0.05 too. Yes.
Mola,
And then
can you
you
just
can
maybe
wash the surface.
explain, Mola, can you just explain it just for surfaces, or do you want to know the room after the patient left, or all the equipment that you
Exactly.
use?
Yeah.
Mola, can you just explain what do you want to
What exactly
decontaminate?
do you want? Yes.
Yeah, for example, there are patients, there are suspected or confirmed patients. That might be rooms, or it might be at home. So mostly we are requested to conduct disinfection.
Oh, is that what you're talking about?
Yes,
Doing environmental spray with chlorine.
exactly. That's what I'm saying.
Really, that is not necessary. We actually discourage it because all you really need to do is disinfect the surfaces. So going there and spraying the whole house like we did during the Ebola era is actually discouraged.
Okay. So we have to be selective.
Mola, we didn't get that. Can
Thank you so much.
Hello?
Hello?
Yes, Anna, you wanted to say something?
Yeah, I just wanted to explain to Mola that what we would say is that we want to clean first, and if it's necessary to disinfect. If you don't have anything else, you can use the chlorine, but just wiping down with an alcohol or any disinfectant will also be sufficient if you just clean first. But we don't encourage spraying, like Professor Shadai said.
Okay.
Sorry, maybe I should. The issue of spraying into the air, and as Anna said, you need to clean, and then you need to clean first, and then disinfect. The issue is that in droplet transmission, what you have is these droplets settling on horizontal surfaces. They're not floating, and all this spraying and making everything wet actually worsens the issue. The virus itself is actually there because it's a lipid virus. It's easily, the lipid coat is easily disrupted by soap and water. But you can disinfect once you've cleaned the place using appropriate PPE. In other words, you're gloved. Then you wipe down. Creating this fluid, wet areas looks good. I like to say that it's good for photo opportunity, but it is not as effective as just cleaning the surface and then wiping, making sure that you're properly protected in doing all this. May I use this, I don't know, over?
Okay, thank you very much, Professor Ogunsola. I think we have similar questions on the Q&A. Maybe Dr. Yewande can help us out to read the questions.
Thank you very much, Idowu. We have a question from Emmanuel. It says 0.05 for ants. I assume he's talking about chlorine solution. So Anna and Prof, if you can answer that. And right after, there's another question. Are there any experiences on using hydrogen peroxide for disinfecting respirators, from Atika? So those are the two questions from Q&A. If you can answer that, thank you.
Okay, thank you very much. We actually discourage using generally 0.05% for the hands. We prefer that you use an alcohol hand rub. However, if you do not have, then it's a disinfectant of last resort. But for most places, there is alcohol hand rub, because with 0.05%, continuous use can lead to dermatitis. And for some people who are asthmatic, the chlorine can be a problem. So if you have other alternatives, if you can use the alcohol hand rub, which is really relatively cheap, that is what we would advise. But if you don't have a choice, yes, you can. Then concerning, what was the second question, please? Hello?
Which was
Hello?
about the peroxide for the mask.
The use of hydrogen peroxide.
This is a very recent
The use of hydrogen peroxide.
Yes, for disinfecting. Yes, this is a very recent, just came out recently. And from what I have found, it's the machinery that you require to do it it's not cheap. So we don't have experience with it. It appears from the literature, it works, but you really do need to get the right specifications and how to do it. We don't have that experience yet. It's a very recent thing, because if you remember, we generally do not encourage reusing, but we now have looked for new ways in the face of the global scarcity of masks and PPE. So the study that was done found that if you used the hydrogen peroxide and used it properly, and it was well done, you could actually reuse the mask at least 3 times without loss of integrity and without loss of integrity and efficacy. Does that help?
Thank you very much. Lizzie, I think these questions are for you. The first one is, with ongoing community transmission, is it still essential to have exposure as a criterion to classify patients as a suspect? If you want me to take that again, with ongoing community transmission, is it still essential to have exposure as a criterion to classify patients as a suspect? Yes, Lizzie, yeah. I think that was for you. Yes, let's take that for Lizzie, and we can come back to Anna and Prof for disinfecting.
Okay, thank you, Wande, for that. Like I said, when I started the presentation, that we're still getting to learn a lot with this coronavirus. So the case definitions are getting to change like very, very often. So I think it's still vital for us to be using exposure as one of when we are screening the patients.
Thank you very much, Lizzie, for that. So very quickly, one says, in settings where the culture of spitting is common, is spraying the surface not prudent? The next says, which disinfectant is suitable for disinfecting surfaces and concentration? And right after, we have something on the use of PVP iodine for disinfecting.
Disinfecting what?
Maybe I can answer the first one on the spitting and spraying. I think this has been addressed about the virus circling more on the surfaces. So what you should do as in environmental cleaning is you first clean with soap and water. Then you can use your disinfectant to wipe off. And if you are using something that is corrosive like chlorine, then after wiping with the chlorine, you can then follow with a clean cloth that has been damped in water so that you remove the traces of chlorine. The spraying has been proven to be not so effective after all. And I'm not so sure of the PVP iodine. Maybe Prof, you can assist.
I don't know about PVP iodine for environmental cleaning. It's an antiseptic and for the skin. So I don't understand in what why, I mean, in what sense this question is being asked.
Okay, thank you for that. So participants, kindly move your questions to Q&A session and I will read it out. If you need more clarity, kindly just put that in Q&A. Okay, so Martha says, here in Sierra Leone, I've seen people adding Dettol to water provided for hand washing. I want to know your stand on this.
I don't think it is necessary at all. Dettol is it's a very low level, it's a low level antiseptic. And since you're going to be washing your hands with soap and water, why add the extra expense? It's not, I wouldn't advise it, but I don't think it's necessary.
Can I just also come in there? We would rather say use soap and water to wash your hands. And if your hands are not visibly soiled, rather use the alcohol rub. But to put Sampic in the water is actually no use. As a process, you're just wasting resources. It's not necessary.
Thank you very much. Another question says, what disinfectant do you recommend for disinfecting motorbike helmets and the handle?
Alcohol.
Yeah, wipe down with alcohol.
Alcohol.
Yeah. Just wipe down, yeah.
With alcohol.
Okay. We have one that says, can we also add oximeter to an emergency material at triage for evaluating clinical severity of possible COVID-19 patients before sending them to the isolation?
Thank you very much. I think that's a good question, but I think there's also a little confusion. The idea of sending them to isolation in the sense of the triage, I think we're talking two things. The first one is that when you've identified someone who is a suspect, you remove him from circulation so that he does not transmit infection. So when we say isolate him, in other words, take him out of circulation. At that point, I don't think you need to put any oximeter. In asking this question, you're thinking of someone we've already identified as a COVID patient and who is going into contact and droplet precautions, isolation. They will be managed by the case management team and they'll be evaluating them. I don't think that is something for a triage level. Those are going for case management and the case management people will handle them and determine what they require, what their symptoms are, how badly they're infected, how bad their symptoms are. And I think at that level, they would determine it. So it's not triage as in the clinical setting. This is triage to remove those who are infectious from those who are not, or who have the disease, or who we suspect to have the disease. And then they will be taken care of, and then they move on to the next level. So at the triage station, they're not doing major identification of symptoms, how bad you are. They move you to the next level. And then at that level, they'll evaluate you.
Okay, thank you. There's another question about triage. It says, should triage be fully on surgical or medical masks throughout?
Okay,
yes,
I can.
Yes, okay, go on, Lizzie.
Okay, I can get to answer that one. For now, like what we're basically doing on the triage is to take the temperature and ask for the symptoms. And we said that you have to maintain that distance of 1 meter and the surgical mask. So for now, and with the evidence that is currently there, that PPE can suffice on the triage area. Because the patient is not spending so much time there. It's just the temperature taking and asking them whether they meet the criteria or not. And then you start moving them according to the algorithms, which will be healthcare facility-based specific.
Let me just clarify, because they will be using a mask. I mean, I think she said that, so it doesn't get lost. Yeah. A surgical mask is fine.
Okay, thanks for that. This says that, okay, so the question about PVP, iodine, and wash is back. As further explained, says PVP, iodine, and wash, and Andro products, question mark, even as nasal spray and gargle mouthwash. So if you can take that, if we still understand or if you need.
No, I don't understand.
So Tosin, please kindly be very clear with your question. What exactly is the question for our panelists and for us? And what would you like to know? Then we can address that. Very quickly, we have something that says, please advise on male transmission of COVID-19 during intercourse within 2 months after discharge from COVID-19 isolation unit.
COVID-19 has not been found in specimens of semen. It has not been isolated. Infectious virus has not been isolated from blood or from urine. There has been one paper or so about infectious virus from stool, but most papers have just been about the RNA in stool. So I don't think there's a problem there, except the patient is still transmitting from the respiratory tract, which is different. So it's not Ebola. Ebola is found in semen and all this. So that's why we have those requirements for after a patient has been discharged. But that's not the same thing for COVID. As of today, we have not found COVID in semen. So I don't think that's a discharge requirement. Thank you.
Okay, thank you very much. We have another one for us on able to isolate from family work. What would be the best to disinfect and keep environment safe?
You're not clear. I can't hear you.
Very quickly, I'll say that again. So the question says, for healthcare workers unable to isolate from family members after work, what would be the best process to disinfect and to keep home environment safe?
Prof, you need to mute your mic.
Okay, I think the process starts from when you are at work. You need to ensure that you're not exposed, which means you have to be properly masked, and that when you do your hand hygiene properly, you wear the gown if you're in close proximity with patients and doing things accordingly. That's the very first process. Because by the time you're getting, and of course you do not use your street clothes in the hospital because you need to take that because it could get contaminated. So when you get home, take off any clothes you've brought in, wash them, have a bath, and then go about your duties. However, if you have not been careful at work, the infection is going to be passed mostly through the respiratory tract. So there isn't really, so it's either you stay in a separate room and sort of do a sort of self-isolation for yourself. That's about all you can do. But there is nothing, and then, I mean, that's the main thing, because if you don't bring it from the hospital, then you don't have a problem at home. So I don't know if I've helped you, because it's a very wide thing. But I think the main thing is for the healthcare worker to follow all the precautions at work to reduce the chances of getting infected. I don't know if anybody else has anything to say that can.
I concur with you, Prof. And for the healthcare worker, like when you're saying that whatever the clothes that she's bringing from the hospital, they should always be washed separately from the rest of the linen. And then there is no harm in them also getting to even strengthen their hand hygiene practices at home, and also practicing the cough etiquette. And once they start developing the symptoms, then they can start isolating themselves in another room while they call the relevant rapid response team to come and attend to them.
If I may also add to that, if you feel you've been exposed, my advice will be self-isolate. If you feel you've been exposed, self-isolate.
Okay, thank you very much for that. Very quickly, we would take, Martha says, how long can one wear a surgical mask? We have answered that on the Q&A, but I thought it would be useful to participants to know what the guidance is for how long we can wear a surgical mask. We also have one that says, what is the most effective protective measure for community in African context? So Anna, if you want to answer that, because you were already doing that on the Q&A.
Sorry, my internet just dropped. I just joined again. Just repeat the question and I can answer.
So the first question is, how long do you have to wear a medical or surgical mask? And what are the preferred or most effective protective measure for community in an African context?
What we normally would say is a surgical mask is only for about 20 minutes, but during this outbreak, they decided that they can use it longer. And Prof. Shadai know that CDC actually posted that paper on that. But as soon as they found that it's starting to get moist, they will have to replace their surgical mask, the healthcare workers. In the community, we would say that the people, if they can't keep to social distance, rather wear a cloth mask, but then also they have to make sure that they clean that mask properly every day, wash it, dry it, exposed to sun or to heat. Also prepare, change their hands, hand sanitizing. If they don't have symptoms, and they can have a social distance from 1 to 2 meters, then they don't need to wear that. But if they, and we know in Africa it's difficult to keep to social distance, that's why we would prefer them to wear the mask and then just change it, have basically one for today and then one for tomorrow, and wash, and try not to touch your face. And if you do, just sanitize your hands.
Let me add to that, because I think it's important that we pass the message across. The cloth mask is not a medical mask. We are all protected if we're all using it. The cloth mask is actually even more useful for a symptomatic person because it can reduce the amount of the secretion or the virus that's coming out into the environment, but it does not replace the other things. Even with the mask, we will still advise that you do a cough etiquette, that that when you want to cough, you still cough into your elbow. We would still advise that you try as much as possible to maintain physical distances where possible. And we would still say, don't go into big crowds because you've got a mask on and you just feel that you're safe. It's not as protective to help you if you are masked and someone who's infected is not masked, it does not stop the virus from being breathed in. Don't forget, viruses are like 0.0, they're about 0.03 microns. They're very tiny, and they can pass through the pores of the cloth mask. Some of the things we've identified that can make a cloth mask safer than another one is the quantity, the thickness, the tightness of the weave. In fact, we advise that it should be a little difficult to breathe through. Some people say if you try to blow a candle through the cloth mask and you cannot blow it out, then you know not too much is coming out. So those are little things, but it is not, and I want to emphasize that, that once you have a cloth mask, you can forget everything else. No, it is part of the bundle. So we recognize that physical distancing can be a problem. So this is an addition to cough etiquette, to hand hygiene, and to try as much as possible to still keep physical distancing, to try to avoid crowds wherever possible. So please, I just want that to really come out very strong, especially when we're advising people. Cloth masks alone will not protect you. I think that's one, but it can add to all the protective strategies that we already have.
I think I just want to add, like we said, hand hygiene and the social distancing and all the practice that we talk about, that all work hand in hand. You can't just do the one and then think you're safe. Same as with that when we talk about people wearing gloves in public and then think they can just touch or disinfect the gloves. That's one of the reasons why we don't want them to wear that, because people think if they've got the gloves on, then they're safe. The same as with the mask. People need to understand that all is part of a parcel, that you need to adhere to all the regulations and all the stipulations we're telling you to adhere to. Because the gloves is also a big issue, especially in South Africa. I don't know in the rest of, but in South Africa, everybody wants to wear gloves when they go to the shops or touch anything.
Thank you very much, Anna and Prof. So I see that there's some sort of trend Q&A where a lot of questions about or cloth mask. One that stands out is how do we disinfect or clean the linen mask? There's another one I think needs sort of clarity. So we have a question about if the disease is not, why are people advised to wear masks as opposed to TB that is airborne, but no advice on mask? I think it might just be important for panelists to just talk about the difference in the droplet transmission and the airborne transmission for COVID. So if you would like to take those two questions about disinfecting the linen or cloth mask and talking about droplet versus airborne transmission, looking at case scenario for SARS-CoV-2 and for TB.
Okay, I can just say on the cloth mask, what we would say is that you can just wash it with the normal detergent and ensure it's dry, and you can put it in a tumble dryer or just put it out in the sun, or just iron it as well. You just need to expose it to a little bit of heat, but normal washing and making sure that the material is completely dry before you use it, that is the most important thing. And then on the droplet, you can talk today.
All right. Concerning the droplet and airborne, I think we always have to go back to this because I think it's something that confuses people. Droplets come out of your mouth. They're usually quite large, and they're usually above 5 microns, and they tend to fall within a meter. Now, depending on the force, sometimes it could extend a little bit more, like if you sneezed out the droplets, you understand. But the main difference between droplets and airborne is that for the airborne, it continues to float in the air, and the organism will still be viable in those droplet nuclei. And there are very few organisms that can still stay in the droplet nuclei for long periods, TB being one of them. Measles can do that. Chickenpox can do that. SARS-CoV, if you create aerosols and very fine particles for a short period, it could be suspended in the air for longer than normal, but it will not stay there for a very long time. It doesn't survive, at least so far, for very long periods like you would find for TB. So at the present moment, most infections will be from large droplets that fall in your face. In other words, you need close contact. So I hope that helps. Hello?
Okay,
yeah.
Thank you. Okay, so the question, we're back to the question on the use of Vidone, iodine, nasal spray, and mouthwash during the current COVID-19 pandemic. And Tosin says that there was an article published in May 2020 and its use mentioned in the UK. It says, I think the outcomes of the paper suggest that it may cross infection and protect healthcare workers. But the context is the use of PE, nasal spray and by healthcare workers. So, and it was a UK context. So the floor is open to the panelists. I know Emilio is also online from Public Health England. If you also like to give us insight on that.
Hi, one day, it's Emilio here. So that paper is not a recommendation from Public Health England. It was a discussion paper. It's not part of our general recommendations to use mouthwash for healthcare workers, and there's no strong evidence that it would have an effect on transmission. All of the other measures about hand hygiene and correct use of PPE have very clear validated effect on transmission, so we put all of our emphasis on adhering to those measures. Thank you.
Thank you for the very there seem to be some questions about corpse disposal, decontamination, how to handle burials, and disposal of human remains. We've had questions from about 2-3 people that want to know how to disinfect, how do you handle burials. So would like to get some our facilitators in terms of what are our recommendations for handling COVID-19 is.
Shaddai, do you want to say anything? Just unmute yourself.
Okay.
Did we all get the question?
Yes.
You want to know the burial? If burial, sorry, it wasn't very clear, but about dead bodies.
Did we get
right?
the question? Yeah.
Yes, I think it's about dead bodies. Is that?
Yeah, they wanted to know what is how to handle the corpse and in burial, what is safe for that. Do we need any special treatment or anything like that? That's the basis.
Well, let me start with the people who would be doing the burial. The infection and the particles, the organism is in the lungs. Dead bodies, once you've stuffed the orifices and you do a proper, you use your, what do you call it? You use your gloves, your proper PPE. It's advised that you also use an N95, especially when you're handling the lungs. Now, for the family, there's nothing wrong in them viewing the body. There's nothing wrong in them burying their body. It's not advised for them to do all the hygiene things, you know, touching, because there's still things to be known, but it's not like an Ebola that you cannot touch. So they can view their body, they can bury their body, and then those who are handling the body should use proper PPE. That's the advice.
Okay, thank you.
Can I, Yolanda, I just want to say that Prof. Mehta also done here in South Africa, they've put down the regulations that you don't need any special treatment of the body. Just like, you know, use your PPE, make sure all the openings are plugged, and then you can just carry on. I mean, and they can have their normal burial. If you do, I mean, like Prof said, it's in the lungs, and if you perform any procedure that it will come out of the lungs, then maybe, but other than that, there is no evidence that there's any contamination like that.
Okay, thank you very much. Very quickly, Susan, on the chat has shared with you the Africa CDC guidance for community use of face masks. That document is concise and touches on various types of masks. As Africa CDC, our stance is medical or surgical masks, and respirators should be reserved for healthcare workers. And that where there is widespread community transmission, it is probably advised to use locally or non-medical face mask. So very quickly, I will just move to the next questions. Please, I want to know the reinfection rate for COVID-19, because there's been reports of people that have recovered from the disease being reinfected again. And another question came up earlier: how can I protect my family if I deal with infected samples with COVID-19 virus?
Thank you very much. Concerning reinfection rate, I'm not sure we have that figure yet. This is still an evolving pathology. We don't really know when you say reinfection, we don't know, is it a reactivation or reinfection? So there's still a lot we don't know. So no, we don't have a reinfection rate. And I think this is still things that are being studied. That's one. Secondly, how do you protect your family if you deal with infected samples with COVID-19 virus? I assume that you're saying that you work in the lab. Your standard precautions. You don't touch body fluids, the normal precautions, because once the organism cannot touch, you cannot contaminate your hands and surfaces that allow you to contaminate your face, then there's no problem. The risk to people handling the virus, samples in the lab, your normal biosafety, when you're doing ordinary body samples. And as I said earlier, infective virus has not been grown from blood. Infective virus has not been grown from urine. In fact, for the lab people working they are probably more exposed when they're trying to take samples than when you're just doing PCV urine tests. But for any body fluid, you really need to do your standard precautions to prevent you coming in contact with body fluids. I hope that helps. Oh, and if you do all the normal lab safety, you'll be fine. Over.
Thank you, Prof, for that. We also have a question. This participant says, I joined a bit late, but I heard you, Prof, make a mention of cloth masks not being adequate enough because the virus is as little as 1 to 1.3 microns. But then again, she talked of it being spread by droplets, which is like 5 microns, and as such, not too tiny. Please, can she throw more light on that?
Okay, let me explain. The size of the virus is, when the virus infects, it infects through fluids that come out of your mouth. When you talk, you sing, so the whole thing, so the virus is suspended in these secretions. And so when you wear a cloth mask, it can absorb it. That's why we said, if one is infected, the person wearing the mask, if the person infected is the one wearing the mask, it's more protective of others than those of you who are just standing around. In other words, if you don't mask the infected person. So don't forget, the virus is inside the droplets, the liquids. The droplet itself is not the virus. And it is the virus is transported in those droplets. So when you have the mask, which it absorbs those liquids, so most of it is kept in. So what we're trying to say is, we cannot guarantee that when you're wearing a cloth mask that has all these large pore sizes, that the virus, that you're absolutely protected. And studies have shown that the best cloth masks, about 50%, give you about 50% the protection of a medical mask. So it is not an absolute guarantee. And that's why you need to still, but it helps. So you still use it in addition to all the other things, hand hygiene, distancing as much as possible. We recognize that can be a challenge. Cough etiquette. So that, and I know that some study was done, if I remember well, but I don't have that off, that it actually limits the distance, even if something comes out through the mask, it limits the distance it travels. So it has some protective functions, but it is not an absolute. So you cannot use it alone or use it and take risky behavior. So the idea is those masks help, but still avoid large crowds. Try and keep away, keep distances. Try and, even when you're coughing, still do the cough etiquette. The idea of the cloth mask is that if everyone is masked, then we're reducing the emission of the virus into the air. So it is reducing, so we are all sort of helping ourselves. So that's the purpose of the cloth mask. And I went into that detail so that people don't get overly confident that because I have a cloth mask, I can do anything, go anywhere. I think that would be dangerous. Thank you.
Okay, thank you so much for that. Just very quickly to remind our participants that we have experts from ICAN, we have from Public Health England and US CDC in the community of practice. We will be able to provide remote guidance and support using the Telegram channel, which has been shared in the chat. Feel free to join this. Feel free to get your colleagues and other frontline workers to join this community of practice where we're able to give context-specific recommendations and guidance. So we'll take a few more questions. Someone has a question saying, what PPE is recommended for radiology department?
Radiology department depends on what they are doing. If they're in contact with the patient, the normal one, I mean, if a patient is coughing or anything like that, or just a surgical mask, try and keep the social distance, and normally just clean the environment, you know, wipe down after the patient's been there.
Maybe I need to mention, because I'm not sure we have the same crowd as last time. You do not need the coverall that you use for Ebola. This is a respiratory tract infection. The most important PPE is the mask. All the others are supportive. So, because a lot of people are shouting, we don't have PPE. And when you ask, it's that coverall that you use for Ebola. For most of us, the amount of contact we have, a gown, you know, with long sleeves, and your mask, that mask is the single most important PPE. All the others support. If you wear everything and you wear no mask, you will get COVID-19. So I think it's important that we recognize that. So if you have, in this period where you're having a lot of, if the epidemic in your country has a sustained community transmission, in which case we do not know which patient has it, and the patient may be transmitting even before symptoms, then the advice would be you should wear masks, you know, when you are in contact. And if you're doing anything that's going to have, you know, that you're going to be touching the patient in a more, should I say, intimate way, for lack of a better word, then you use a gown. So I think we should just not forget the mask, the mask, the mask, and to do all the other things that we need to do, the hand hygiene and so on. So if you're in contact with the patient, please wear a gown as well and gloves.
Okay, thank you very much to our facilitators and our participants. We are rounding off the Q&A section. My colleague Idowu will take one last question and that has been raised over the last couple of minutes. So right after that, I think Anna wrap up for us.
Thank you very much, Wande, and all our panelists. So is Ogugua, but it seems he has dropped his hand. Maybe he's no longer, or probably his question has been answered. So if we have any in the Q&A, maybe we can take one more before we call it a day. Over.
So I think
there's one question I asked about, as our hands can transmit virus, our body can do so if infected. Can they just maybe say a bit more what they mean with that, or what's the big question?
So I think we need to say this. I think what they're saying, if our hands can transmit virus, our body can do so if infected. You're not infected, you're contaminated. The virus does not penetrate skin. It does not go in through wounds. unlike the Ebola virus that can go through wounds. So any surface can be contaminated. In other words, the virus can land on it, and that's why we'd say wear a gown if you're going to be in close proximity with the patient. So it's not because the virus will penetrate through your skin or go through a wound. It's only that if your clothes are contaminated, you could use your hands and transmit it to your face and breathing the virus. So that's the only thing. It's not because the virus goes through your through cuts in the skin. It doesn't do that. So even if it landed on your skin, it cannot cause COVID unless it gets to your respiratory tract. So that's the bottom line. So if you do you clean up, you do your hand hygiene, you wash, you take off clothes that are contaminated, you're fine. So. Thank you.
Okay, it's now.
Okay, thank you very much, Prof, and thank you for all the very enlightening questions from our participants. So Anna, over to you to wrap up.
Thank you very much to everybody. We still see there's some questions we will still answer. All the presentations will be made available with the link that you've registered. So we will get back to you, and if there's anything more that you need to know, you can just send us your email and we can respond to you by that, either on the Telegram or on the Q&A. Thank you very much for everybody, and we'll see you next week, same time.
Thank you. Bye.
Thank you. Bye.